Aspiration is when then the food passes the glottis. Occasionally the patient coughs it out. Sometimes the patient does not give a response also, which is silent aspiration, highly dangerous. Agreed? Food going down into the subglottis, no response on the patient's part. This is silent aspiration. This is the proforma for fees reporting that we use. Yeah, something about ice chip policies. There is a certain subsection of patients you might encounter who you're not sure whether they'll aspirate, who you're not sure whether they'll swallow at all. What do you do in these patients? Give them feeds? No. It's a good idea to give a block of colored ice over the patient's tongue. See the movement of the water. What happens is the cold induces the patient to start swallowing, and if the patient does aspirate, it's water finally, which is relatively safe. So, ice chip testing. What's the clinical impact of doing a fees examination? It's of course earlier decannulations, earlier Riles tube removal. You get to change your feeding strategies. Some patients may not be doing very well with liquids. You change them to semi-solids and they do very well. Alternately, the other way around is also true. You have an earlier upgradation to oral feeds if you do a fees. This is well documented in scientific literature. And finally, improvement in the mortality rates in neurological patients. You must remember that post-stroke, the number one killer is aspiration. In the next 1 year post-stroke, 20% patients pass away because of aspiration-related pneumonitis. Fees can bring that down significantly. Just a couple of slides about, you see, while fees has been primarily promoted or talked about as a pharyngeal evaluation procedure, it's not completely useless for the oral cavity or the oral phase also. What can be done is, we can go in through the nose, invert the scope so as to around the soft palate, so as to give you a retroverted view of the oral cavity, and then see the swallow or see the condition of the oral cavity during a swallow. It's not as easy for the patient and the patients are not as compliant as a fees, but nevertheless it can be done. You see, this is how a O-fees is done. You go around the soft palate and see the oral cavity from behind. What you can see is oral stasis. There is food residues in the oral cavity. You can see that there is improper movement of the soft palate and sometimes there is no connection, no whiteout even here, or you can see a very good clearance of the oral cavity. This is a little more important in patients of head and neck cancers who have been operated. So O-fees is a good idea. And finally, endoscopic evaluation of the esophageal swallow. You see, while fees has never been propagated as an investigation modality for the esophageal swallow, there is something called a goose, which is guided observation of swallowing the esophagus. We can advance a scope. You need to have a longer scope though. You can advance a scope into the esophagus during the act of swallow and see the patient's movements, the food movements in the esophagus, and see as the food passes away into the lower esophageal sphincter. That's what we are doing out here. You see, that's the lower esophageal sphincter. It goes on into the stomach. Motility disorders, holdups in the esophagus can be diagnosed with this. It's a very safe procedure. Fees, at the most, the patients are a little uncomfortable occasionally. Laryngospasm, unless and until you go very close to the vocal cords in your attempt to elicit a laryngeal adductor response, does not happen. Always touch the area epiglottic folds, don't touch the vocal cords. Rare cases of syncope have been noted in literature, but then I've hardly seen any. Thank you very much. Questions?
I have only one question.
Yes, ma'am.
What is the record it and play it in slow motion, because when you actually do it, there's only a figure of seconds and everything. What do you do?
So,
What else?
by
Sir,
appropriate,
it's a humble request. We can demonstrate all these things when do hands-on. We are already running it. Extremely sorry to interrupt. Madam. No, we can continue during the
okay,
hands-on.
yeah,
Thank
yeah,
you.
we can do that. We can do that.
We can welcome next speaker, please. Thank you.
हाँ सीवी बनी है ना.
After an in-depth
हाँ ठीक है वो तो कर
knowledge
देंगे
of
अभी किया
these,
ना.
I now invite our next speaker, Dr. Rishi Srivastava sir.
अरे वो पहले का ही बना था यार, इनने नाम बाद में चेंज किया ना. ये वाला भी ये पहले वाला भी होगा. अरे रुको अभी देखते हैं. हाँ अभी मेरे को भी याद नहीं है उसको.
Good morning, sir. As Nilanjan sir has told about fees, now I'll be talking about VFSS. What I think we all are mostly Hindi speaking and Hindi understanding people. So in between, for the better understanding sake, I'll be using Hindi words also. Video fluoroscopic swelling study. The first thing, these tests are for dysphagia. We should know what is dysphagia. Dysphagia means difficulty in swallowing. Means patient is not able to swallow, or he is taking more effort or more time to swallow. If he is taking more than 10 seconds in his oral phase only, he is suffering with dysphagia. If the things is taking more than 10 seconds going from the esophagus, he is suffering from dysphagia. If he is taking more than 1 second in his pharyngeal phase, he is suffering from dysphagia. Either he is, for the swallowing, he needs to does these things, he is suffering from dysphagia. Dysphagia is very common. More than 50 years of people, 5% at least population is suffering with dysphagia. When it is more than 60 years, at least 15% of general population is suffering with dysphagia. More than 80 years, more than 80% people are suffering with dysphagia. When you come to the causes of dysphagia, they are widespread. Head and neck cancers, neurological, neurodegenerative. At least more than 50% of these patients are suffering with dysphagia. When you go to the neurodegenerative diseases, Parkinsonism, MNDs and all those things, more than 80% people are suffering with dysphagia. In pediatric population, 5% of the normal born child are suffering with dysphagia. When they are suffering with CPs or neurodegenerative problems, more than 80% of those poor children are suffering with dysphagia. Now coming to the topic. Two things are there. Broadly speaking, three phases of dysphagia is there: oral, pharyngeal and esophageal. These are all continuous. For sake of our better understanding, we have split into the phases. Video fluoroscopic swelling study is the gold standard because we are seeing from the oral cavity till GE junction, the whole thing from the oral cavity to the pharynx to the GE junction. First time it was used in 1965 by Donner. Then Logman has modified it and propagated it and put the term modified barium swallow. We use barium. Barium is used because we are using X-rays to image these patients. X-ray, to have an image on X-ray of the food, we need to put some radio opaque substances, and barium is most safe because it is not water soluble and it is not damaging kidneys. Gastrografin and other things are there. In all the cases of dysphagia, when you are using video fluoroscopy, you have to use barium sulfate except when we are suspecting any perforation. Otherwise, in that cases, only you use gastrografin. Yeah, like when you are suspecting esophageal fistula, then you should not use barium sulfate. Otherwise, in all cases, you have to use barium sulfate. Normally we use 60% of barium sulfate weight by volume. We can increase or decrease, but for your better standardization, you need to stick to one consistency, and you can increase or decrease barium consistency. Either you use barium paste and all those things, or just put barium in the different consistency of foods. You can use barium pill also for esophageal pill dysphagia diagnosis. It is gold standard. We have already talked about, and while using this video fluoroscopy, you can know the causes of dysphagia, and you can have effective therapeutic strategies like postural changes and different maneuvers to know the effect what you are giving to the patient. The standard BFSS protocol I use with the help of CM. Even in US now all these things are usually done with CMs only. CMs are well equipped with all these things. You can have a recording facilities also. On the lateral view, from the lip to the C7 and from the soft palate to the C7 junction, you can have this image for the lateral view. You start with the liquid boloid and give some semi-solid. You put barium on this semi-solid, and you can last for the solid. You can use the biscuit or the cookies. For the AP view, AP view is used for detecting the lateral asymmetries. Like when you are suspecting or when you are seeing that only one side of the pharyngeal face is not working, or only one side of the soft palate is not working, only one side of the tongue is less movable, then these things can be detected easily on the AP view. In the esophagus, you can see that how barium is passing, whether it is taking more than 10 seconds or not, any mass defect is there, or any filling defect is there, any stricture is there. You can put a pill of 13 millimeter or above size to know that whether patient is suffering with pill dysphagia. Many times what happens that patient says कि खाने में दिक्कत नहीं होता है, पानी पीने में नहीं दिक्कत होता है, दवा नहीं निकल पाते हैं. That is known as pill dysphagia. Either it may be due to the mass or stricture, or more commonly it may be due to the localized atony of esophagus, or sometimes solid induced spasm of the esophagus. Specific parameters, when you are seeing the oral phase, you see the oral onset time. आप मरीज को बोलते हैं कि निगलिए. The time you give the command and the time when his tongue starts moving, that is oral onset time. It should be less than 0.5 millisecond. Oral transit time, the blade of the tongue or the tip of the tongue pushes the bolus towards the base of the tongue, that is oral transit time. It should be less than 1 second. Pharyngeal transit time, it is less than 1 second from the base of the tongue till upper esophageal sphincter. The bolus travels in less than 1 second. Onset of swelling reflex. When the patient is swelling, when the bolus is passing base of tongue, the hyoid movement should start. Means it goes up and anteriorly. This should start, and this onset the swelling reflex. It should start when the bolus is near the base of tongue or fauces, or the bolus is in varicula. We can see the hyoid movement, at least 5 mm anterior and 2 cm upward movement of the hyoid or hyolaryngeal movement should be there. Esophagus, more than 10 cm, more than 10 seconds of duration. If it is the bolus is taking to pass from the esophagus, it is abnormal. You can see obvious dysmotility, any obstruction, any filling defect. Many times for the dysphagia patients, in my clinic, I use C-arm or the video fluoroscopic swelling study for what you can say as a screening method. Specifically, if you see that oral and pharyngeal phases are normal, and for the esophageal phases, you can't send for every dysphagia patient to get an upper GI endoscopy. So if you see that any filling defect is there, please suspect that patient is having mass in that part. Symptoms that can be observed in oral phase: the tongue movement, the jaw movement, the mandibular movement, the posterior spill is, anterior spill is, and you can suspect that the muscle which may be weak and the nerve supply which may be weak. In the pharyngeal phase, swelling reflex, nasal penetration, prolonged pharyngeal transit time, any residue in valvular. See, in the oral phase, I have told you that the tongue pushes to the base of tongue, then base of tongue along with the pharyngeal muscle push the bolus down towards the upper esophageal sphincter. This creates a pressure for the upper esophageal sphincter to open. At that time only, during this time only, the hyolaryngeal elevation is there. This elevation also causes upper esophageal sphincter to open. So by these things, the bolus naturally goes from the upper esophageal sphincter and it doesn't go towards, towards the nasopharynx and towards the larynx. There may be residue in piriform sinus if the pressure is less. Incomplete epiglottic closure may be there. There may be impaired upper esophageal sphincter opening, penetration, and all those things can be there, which you can see also the esophageal phase abnormality like duration, motility, obstruction, filling defect. Disadvantage, radiation exposure. Radiation exposure is exaggerated thing in this. See, the chest X-ray is having 0.01 millisievert exposure, millisievert radiation exposure, but video fluoroscopic swelling is 0.04 to 1. For a video fluoroscopic swelling study, if you is giving taking the time for 5 minutes, the exposure is 1 millisievert. But naturally, we are taking less than 50 seconds from the oral, oropharyngeal, and esophageal. So it is hardly having less than 10 X-ray exposure. If you say for the CT is taking more than 20, 30 to 50 exposure than the one video fluoroscopic swelling study protocol. So radiation exposure is nothing of a concern in normal video fluoroscopic swelling study. Actually time is less, so it is very difficult to finish me. Potential difficulty is the position of the patient, but on the wheelchair also I used to do with the CM because CM maneuverability is better. Face versus video fluoroscopy. In the face you can see the mucosal anatomy. When I am combining in my clinical practice the 90-degree laryngoscopy along with the video fluoroscopic swelling study for the dysphagia patient, almost every disadvantage of video fluoroscopy is covered if you combine these two. Like we as an ENT surgeon, we are regularly using 90-degree laryngoscopy. You are seeing the mucosa, you are seeing the secretions, and we combine with video fluoroscopic swelling study. More or less, more than 99% you are having sure that you have covered everything and you are seeing everything and you are not missing anything. This is the CM machine. These are the gadgets I use for the protection, the lead apron, the lead head cover, the thyroid shield, and all those things. This is me. This is the William Swallow. This is my staff using all these things. A glimpse of few seconds of the different phases. This is the oral phase. You can see the tongue. This is post-operated patient, CA tongue patient, operated twice and radiotherapy. The tongue movement is very less. It is not able to push the bolus freely, and so cricopharyngeal. This is the normal phase. It is going. This is the esophageal phase. See normally how it is going smoothly. This is the heart. Oh, sorry. Pointer. This was the heart. This is the stomach. While in the other video you can see that this is the esophageal dysmotility. You can see that William is stuck over here. Nasal regurgitation you can see in this video. Over here the nasal regurgitation is there. In this you can see that Cricopharyngeal problem is there, spasm is there. I am just showing pharyngeal residue. You can see the video. The residue at the pharynx is there, and it can later on. The pill dysphasia. You can see the pill is stuck. It is not going in the esophagus. It is stuck. This is typical case of pill dysphasia. This is the cricopharyngeal stricture is there, and when he is trying to get, he is aspirating all these things. The silent aspiration. See, he is aspirating, massive aspiration, but he is still not coughing. This typical case of silent aspiration. Esophageal dysmotility, I have already shown the video, cricopharyngeal bar, different things, anterior cricoid way, almost everything I have seen in my clinic. Every type of dysphasia. These are all my videos. See what is happening to the esophagus. Nutcracker esophagus is there. See what I was talking about, this thing. This came with a little dysphagia. When I have done, I saw that the filling defect is there. Then I sent the patient for upper GI endoscopy, and he was suffering with this C esophagus, retrospective diagnosis, the achalasia cardia, the bird beak deformity. I have done in 3 months patient also. I have done in 2 months children also. This was not able to get bottle feed, so I fed it with spoon. We can see from the oral cavity to the esophagus. All these things, whether the child is aspirating or not. I have done in the minimum, I think 1.5 or 2 months old. I have done all those things. So video fluoroscopy in children also, everything. So video fluoroscopy, if you combine with 90-degree laryngoscopy, you are the best just to diagnose the dysphagia. Don't think that only the upper GI endoscopy will diagnose dysphagia. No, they see beyond upper esophageal sphincter. These GI people. So you are missing up to 70 to 80% causes of dysphagia, if specifically in severe patient and neurodegenerative, all those. The maximum bulk of dysphagia occurs in oral and oropharyngeal phases. So it is onus on us to diagnose this patient. They are in large amount of number, these patients. We are undiagnosed, they are on Ryle's tube feed, and we should try to remove the Ryle's tube feed, remove the tracheostomy tube, so that we can feed them naturally to prevent them from malnutrition, chest infection and death. Thank you.
Thank you, sir. We now have a demonstration on assessment of swallowing by Dr. Lva Summit.
अभी इनका वो पलक सूर्यवंशी का वो
Thank you very much both the speakers for excellent presentations. Thank you.
कर रहा है तो वहाँ ये PDF वाला उसका कौन देगा PPT वाला
पीपीटी वाले में
देख वो काजा कौन
मनीष मंजिल कर रहे हैं ये वाला भी, उसके बाद ये अपने ही लैपटॉप से वो करेंगे प्रेजेंटेशन। डेविड राव का यहाँ पूछता हूँ यहाँ पर
मोमेंटोस कहाँ रखा
मोमेंटस वहाँ पे रखा था।
रखे होंगे ना, अभी दे दिया ना।
हाँ
वरुण को वहाँ भेजो, तुम यहाँ बैठ के वो प्रेजेंटेशन वगैरह का जो है ना, अच्छा वरुण से एक बार समझ लो प्रेजेंटेशन कर लेंगे।
You all want to move forward just in case we are unable to see the screens? Okay, okay, fine, it's good. You are able to see us.
यहाँ से सीधे जाओ। मैक है ना, एप्पल है तो
हाँ ना,
हाँ
हाँ ना।
वो वाली चेंज है
नहीं हमारे पास वो वाले भी अच्छे ही हैं। इस घटिया चीज़ को कहाँ से हटाऊँ?
Alright, so we are using a flexible nasolaryngoscope for the fees examination. Alright, this is roughly 3 millimeters or what? 3.6 millimeters in diameter. Alright. The tip diameter sometimes is a little more than
वो मोमेंटो का बॉक्स कहाँ पे
साइड में इसका कुछ इशू है क्या?
मोमेंटो का बॉक्स
No anesthesia whatsoever.
नहीं पता।
अभी एक भी दिया नहीं तूने।
अरे जैसे जैसे
हाँ
Someone is very uncomfortable, you can use a little lubricants for the nose. And certainly no anesthesia, no sprays.
ये तो कुछ भी नहीं है।
है तो ये इसका स्लाइड्स होंगे ना, डाउनलोड कर।
नहीं इतना ही
ये
है।
मेज है भाई,
हाँ ना वही तो।
नहीं तो उसका पूरा वो खुला।
ये वाला है क्या? नहीं ये तो अभी अपना है। ये तो अपना वाला है। इमेज ही।
अरे पीपीटी लेक्स लिखा दो।
अच्छा
Is this screen visible to everyone? Alright.
अरे एक मिनट OBS लगा ना। कहाँ गया? बंद मत करना भाई।
मिनिमाइज है हाँ। रिकॉर्ड हो रहा है कि लाइव स्ट्रीम हो रहा है?
ये कौन सा, ये कौन किसने दबा दिया यार? कौन दबा दिया?
So now there are patients in whom you will know that giving them water at the outset. Order of feeds can be a little customized as per patient. Water is not routinely done, nowhere in the world. We do water because water is a safe consistency to drink. Even if he aspirates water, it's okay. So usually the question is whether to start off with thicker feeds or thinner feeds. That depends a bit on one, the patient's original pathology, the neuropathology of the patient was. Two, for example, say a patient has lateral medullary infarct. Okay, a lateral medullary infarct patients tend to have cricopharyngeal dysphagia, which means I'm audible?
किसी ने कुछ इसको छेड़ा है क्या?
Cricopharyngeal dysphagia, which means
तो फिर इसका ये व्यू कैसे चेंज हुआ इसका?
पता नहीं। Pyriform fossa. Alright.
मतलब मेरे सामने तो नहीं
It's
छेड़ा।
less a question of aspiration, more a question of food staying there. So these are patients in whom probably residues will be higher to thicker consistencies because the cricopharynx is not open. So these are patients in whom you start with a thinner consistency. Alternately, a patient who keeps complaining that he has cough on feeds, especially liquids, or the patient has got a pharyngeal and upper vocal cord palsy. That is something which you see. This is a patient in whom I would probably like to start with a thicker consistency, not a solid necessarily, a thicker consistency. There is also a consistency rating across the world which is called IDDSI. International Dysphagia Diet Standardization Initiative, which is rated from 0 to I think 7. 7 is normal, 0 is your thin water. So roughly I would use a IDVSI 5 for a patient who might be aspirating water. Yeah, that's another question that, let's do this quickly, that's another question that needs to be answered, whether to use a scope with a suction or without a suction.
This side so that we can stand properly.
This should not be crossing. थोड़ा उस तरफ ले लो. This side. बहुत बढ़िया. Yeah, very good. Very good. Screen visible to everyone? Alright? Start with Harsh, who's actually volunteered and now. Always a good idea to do a meatoscopy. Meatoscopy is something to see here. A meatoscopy is something to evaluate each nasal cavity, see which is a little roomier. So this is a long scoping, mind you. The patient is going to be a little uncomfortable at some point. So always see which is the area nasal cavity and then going through the stage. A question would also arise if there's a rise to what to do. We'll answer that in a bit. So we advance through the nose. Now while you're going in through the nose, it's a good idea to go in again the inferior turbinate rather than the septum. Bolo. Alright.
Connector.
Swallow करो एक बार. You realize that the swallowing, the contraction while swallowing is
कैसे capture है क्या?
ER is a little different. The contraction while swallowing is a little tighter.
क्यों उसी से कैप्चर है क्या?
Behind the this is where
चाहिए
yeah, this is where
अर्जेंट लिए
the exact position. बहुत बढ़िया, बहुत बढ़िया. No secretions, हमारे scale 0, हमारी secretion scale seems to be okay. थोड़ा पानी में start giving him water. This is usually colored with something. You don't have a lot of food dyes out here. You manage to do what you manage to do. That is how an ideal swallow should be. You don't get to see the food at all. It just comes into your pharynx. It's just come into your pharynx. You get some whiter and it disappears. After the swallow, you need to go down into the laryngeal residue, see whether there is any aspirated or penetrated material. Also see the piriform fossa and the valvula for any residues. No one? No, not that. And what the milk? Yeah, milk, right?
This is a non-anesthetized patient.
Non-anesthetized patient. This is where the scope needs to be maintained. Because there are lots of reasons for this. This gives you a panoramic view. Not only that, your scope does not get clouded by the food that's coming in.
He's already taken, right?
Yeah, he's already taken it.
स्टार्टिंग को नहीं दिया लगता है सुबह
So this is what, this is trace residues according to fees, but the video fluoroscopy would just rate this as no residue. So this is not really significant. It's, the coating of the glucose are a bit of milk. Banana. Mashed banana, mashed banana. Very fast. This is a normal sound. Now you realize that you just saw the banana and then it disappeared. Did it? एक बार फिर से बड़ा बोलो इसको.
ज़्यादा दो ज़्यादा
Sorry, Raj.
again gone
See, it just comes into the value यहाँ पे आता है and disappears. Okay. दही है क्या है? Biscuit. This is IDPS and cell. But it takes a lot of effort to keep your scope non. So now biscuits arrive here and then it disappears. This is a normal solid. One more time. Yeah, biscuit is also nice. So we get biscuits directly also. And then there is no provision for giving up. During a freeze examination, there is really no provision for giving unmashed bits. We are actually checking facts. So that's done. What we do is
चलेगा।
slowly advance the scope. Touch the area did not enfold. He coughs. Yeah, I know. Sorry. And that's done. Okay? That's his laryngeal sensation. Sure.
Thank you for
तो बड़ा बोल रहे ना तुम तुम्हारे पास से
Thank you very much. He was very gracious to us.
नहीं हो रहा ना, ये बड़ा ही है। ये कौन सी स्लाइड है? इसमें इधर देखो कौन सी स्लाइड है। वहाँ का सेट हो गया क्या? कि वहाँ पे लाइव कैसे करेंगे तुम ये बताओ।
हाँ
वहाँ पे लाइव कैसे करेंगे? ये है कहाँ का? पहले ये तो देखो।
यहाँ क्या है ना ये डेविड लाओ जो उधर का हुआ है उधर है डेविड आज नहीं
ये तो साइज तो ये सही तो बना है।
नहीं
वो
ये
तो तुम्हारा वो भी ऐसे ही आ रहा है।
नहीं इसको वो करना है
Secretion rating is.
बेसा
You have to decide whether
साइज
you
क्या
want
है
to go ahead with these.
ये इधर से।
Each patient does
यहाँ
not
से।
have to
ये इसके
defend
बाजू से।
themselves.
क्लिक पहले
This
करके
is done
पूछते
in two parts. The first is a dry swallow part wherein you actually evaluate the
ठीक
patient's
है, कहाँ?
status. The
ये?
second part
500
is where you
पिक्सल है।
actually
तो
take the
कहाँ
patient.
मैंने चेंज करना
You
हो
don't proceed to feeding as
चेंज करने वाले बता रहा था
अरे ऐसे चेंज नहीं होता भाई।
यहाँ से होगा
अरे नहीं, यहाँ से नहीं होगा कहीं से।
मैं कह रहा हूँ पूरा फुल कर दो क्योंकि वो ऐसे बर्ड में रह रहा ना
ऐसे में बढ़ाना है कि ऐसे में बढ़ाना है?
ऐसे में
ये इससे चौड़ा नहीं हो रहा, ये बोल रहा हूँ। वहीं से चौड़ा कर दो ना इसको।
नहीं हो रहा ना कट जा रहा है अंदर से कट जाता है मैं कह रहा हूँ
उसका व्यू नहीं आ रहा है, नीचे देखो कहाँ भाग रहा है।
वो व्यू वहाँ से सही है नहीं वो तो मैंने अभी लोगों वो सेव करा हुआ नहीं जो चलना है ना अपना
So there are two aspects to that question. Yeah, sorry. Am I audible? One would be comfortable. The examiner would be comfortable doing a scopy with a suction scope because he gets to aspirate out material, he gets to have a better
ले लो ना
visualization.
वहाँ से।
वो नहीं दे रहे ना
You must remember that a scope with a suction is also going to be a
तो मैंने
scope
लिया
with a
है।
bigger
अभी ये
diameter,
चलने
a
दो ना,
wider
ऐसे
hole.
तेल लेने जाना।
Going in through the nose,
नहीं वो तो चल रहा मैं तुम एक बार वो स्लाइड कर लो इस साइज में कर दो बस
you have to
नाम
draw median.
ये
There are
पीपीटी साइज
patients
में।
whom I might want to
हाँ?
do one with a suction
हाँ
scope.
बस
There
वो
are
सिंगल
patients
नाम
whom I
डाला था ना
might want to do with just a plain scope.
Okay,
Like in him,
नाम डाला
he does not require a lot of suction.
ये वाले?
This is a person in whom
तो
doing
क्या
it
सही है?
without a
अच्छा, रुक
suction
जाओ।
scope is the best idea.
दो
The
में पे
patients
अपडेट
who
कर
might aspirate, who might need a little
यहाँ नहीं होगा
clearance,
ना वो।
might need a little clearance of saliva secretions.
Well,
Those are patients in whom you might want to use a suction scope.
फैल गई क्या फैल गई हाथ से बनते
And you suck out the saliva. So that was just one part of the story. The other part is
पेंच तुम तो
there are
डायरेक्ट बड़ा कर देते हो ना
vestibule or if there's some food
ये।
which has
अरे
gone
उसमें
to
बहुत सारे नाटक हो जाता है भाई, कॉपी बन जाती है
suctioning it out
उसकी।
with a young
320
person is very
10
challenging.
कितना पिक्सल्स में?
ये 1920 ये 1080 कर दो
ये
हाँ
So if you have a Riles tube in
तो मजाक समझते हो साला कि उठा के चेंज कर
this is
दो।
a sort of prolonged study that we have been doing.
Copy
If you
हो
have
गई।
Riles tube in situ, the obvious
कौन सा
answer
वाला
would
हो
be
रहा है?
going through the other nostril.
क्या
I have seen time and again that it's always better to go in through the nostril with
ये
the
वही
Riles
है,
tube. You
वही
get a
साइज
better
आया ये तो।
visualization, the patients are little more comfortable.
साइज चेंज करूँगा 500
The
500
patients are
वाला
little more comfortable, most likely because the nasal cavity has become hyposensitized because of the Riles tubes being inside. And there's
This
also the
side,
off
this
chance
side.
that the Riles tube has been inserted in the more roomy cavity. So
The thing is
you don't need a Riles tube. Now I've started doing, that is another question that's actually in
ऐसे बोल रहे
patients
बस।
whom we feel might get off a Riles tube.
बस ऐसे रह दूँ?
Want to remove the right tube.
उधर के भी कर
Microscope
दो,
with the right tube
अपडेट
and
करवा देता हूँ, एक बार चला के देख लेता हूँ.
doing a study on that. But in patients whom I'm pretty certain will require the Ryle's tube later on too, it's a good idea to have an understanding of the swallowing physiology with the Ryle's tube.
अच्छा तुम एक काम करो, इस पे LT6 ये LT6 वहाँ चल रहा है कि यहाँ चल रहा है?
LT6 उधर है.
Suppose we have allowed it.
ये भी बड़ी समस्या है, ये 6 है.
इनने क्या परसों के दिन नाम चेंज कर दी इनको करके.
You will have to
हम
take
एक भी
into
चला के
account
देख रहा हूँ.
the Ryle's tube in situ. So it's a good
अपडेट
idea
करके
to
चला
know
के
what
देख
the
रहा हूँ.
swallowing is like with the Ryle's tube. That's
That alter the swallowing
yes.
physiology,
So
there is a
there are what 2 or 3 papers across the world. Yes, certain things do change. Residues change a bit, but then in a patient who might go home on a Ryle's tube, we have to ensure that we know what the swallowing physiology is like with the Ryle's tube. If the patient is aspirating with a Ryle's tube in C2, and he's going to be on a Ryle's tube, it's as well that we know that and we avoid those consistencies. Yes, it does alter. You need to take into account what is altered because of the Ryle's tube and then take your decision according to it. Yes. That's huge question, huge topic. It's an entire 3 things. Does cuff actually change your swallow? Does the tracheostomy hitching to the skin change your swallow? I believe that tracheostomy hitching to your skin, allowing for reduced laryngeal elevation, does change swallow up to a certain extent. Definitely increases the chances of residues from what I've seen so far. The cuff inflated will not cause pressure on the esophagus to cause holdups. But the cuff inflated, there are studies to say that the chances of its aspiration have increased with an inflated cough. But not all, not all patients do have the luxury of downsizing or inflating the cuff and doing it. There are lots of patients who have secretions. There are lots of patients who, are borderline swallows. So no, we cannot deflate the cuff in each patient. Just the cuff being inflated with say roughly 20 centimeters of water is, I think, it does not impair swallow tremendously. Again, that is something. Both the Ryle's tube and TT have to be taken into account mentally, and then you need to proceed with your fees. Yeah.
Any other
It's
questions
like
from the
it's
delegates?
It's like any other branch of laryngology. Dysphagia is a huge, subspecialty. It requires a lot of dedication. It requires a lot of dedication. And these patients are not one-time patients. They keep coming back to you after a month, after 6 months, after 8 months. I'm sure all of you must have encountered Bharti ma'am, you ma'am.
Because any neurological disorder
It's-
will land up.
it's-
And also the longevity is more in India now.
Absolutely.
We have 69 years. So women,
That's-
less,
That's exactly what I was thinking. Because of longevity increase, number of neurological problems have increased. Be it Parkinson's, be it Alzheimer's, be it your strokes. Because of this, dysphagia patients are also on the rise.
So what is there to treat?
Everyone is doing, I think, in their own individual way, I'm sure. Okay. But then yes, it needs a little more focused approach, I believe. You're right.
It means very less people who are treating dysphagia, just putting Ryle's tube.
Whether it has to be done by Indian research or it trained
This struggle is going on now. I believe that an ENT surgeon is very necessary while doing a fees examination. The problem is there are certain clinical correlations that one needs to do. That I think somewhere the SLP training is lacking there. I am not contesting the actual performance of a fees. That may be possible by a SLP too. Unlike video stroboscopy, which can be analyzed any time later, and you make a diagnosis, you can probably treat that patient. It's always a good idea to be present during the fees examination. There are subtle changes, subtle dynamics which picking up later is very, very difficult. You might feel at that point that this patient has got a poor laryngeal elevation, and maybe if I do a Mendelssohn's, maybe if I do something to hitch up his larynx, this might work. The treatment plan, not just in terms of therapy, sometimes in terms of surgical treatment plan also. Say a patient who has got some cricopharyngeal tightening, I might want to give Botox at some point. These are patients I think that ENT is better served doing. SLP you can have alongside probably, but I would still suggest ENT personally.
So thank you very much, sir.
Thank you very much.
The announcement for the those who have registered for hands-on, they will be given an opportunity for that also, but in some separate room. So you have to wait for that. Thank you, Dr. Nilanjan sir and Dr. Rishi sir, for excellent presentation and demonstration, and to respect the time also. Thank you all. Thank you.
Thank you, sir. We now move on to our next session, Senior Consultant Paper Presentation Award. I would like to invite the judges for the session, Professor Dr. Bharti ma'am, Professor Dr. Vikas Gupta sir, In the meantime, may I request the chairperson, Dr. Anil sir, to please present memento to the speakers. Dr. Nilanjan Bhaumik sir and Dr. Rishi Srivastava sir. Please be on stage.
No, thank you so much.
Moving on to our senior consultant paper presentation, I now invite the judges, Professor Dr. Bharti ma'am, Professor Dr. Vikas Gupta sir. I now invite the speaker for the session, Dr. Kavita Sachdeva ma'am.
सबके हैं भाई
Good morning, everyone, dear chairpersons and dear audience. I am sharing my institutional experience of voice disorder patients in our college. So, change the slide one, change करें. Okay. So, we all know what is voice disorder. It occurs when the voice quality, pitch, and loudness differ or are inappropriate for an individual's age, gender. So it can be a voice disorder present when the person is telling that I am having voice disorder, maybe the audience don't agree. So then also we have to consider it. So what are the aims? To evaluate the etiopathogenesis of voice disorder, its correlation to severity of dysphonia, its endoscopic correlation, and application of standardized voice assessment tools to it. So we have done a retrospective study, and it was done for past 5 years sample we have taken, and inclusion criteria was dysphonia more than 15 days, and it was not including any frank case of malignancies, only the complaint was dysphonia more than 15 days. Now it was a we took a detailed history, examination, and neurological evaluation was done, voice analysis was done, and we did KV analysis for the following parameters of roughness, breathiness, tone, pitch, loudness, and overall severity, and scores were given out of 100. And then we also do the acoustic analysis by WAGMI was used for jitter, shimmer, and then we did the quality of the voice was assessed according to the subjective evaluation. So out of the 1 lakh, more than 1 lakh patients we have received in the past 5 years, the prevalence of voice disorder was 0.12%, and the male patients predominated in our sample size, and age group was 21 to 40, and then followed by 41 to 60 was the prominent age group which presented there. Now we have used it Kaufman-Essexon's classification to grade the professional voice users. Level 1 was singers, actors. Level 2 professional voice users like clergymen, politicians, and teachers. Level 3 included doctors, lawyers, and the workers, and level 4 was non-professional, non-voice users, liberal, lawmaker. Then we have made one more category of unemployed, and we can see the distribution of patients. The elite group 1 are very less representative. Maybe it is a government set of the patients are not coming. And the maximum patients were the grade 4, that is non-vocal and non-professionals. Now if we see the etiological factor, smoke, alcohol, emotional stress, trauma, tobacco, all these were present, and in 56 cases, and none etiological factor was present in the 74%. Then these are the distribution of comorbidities. So in comorbidities, hypertension, type 2 diabetes, CVA, mediastinal mass, thyroid disorder, and CAD and meningoencephalitis and lung diseases were present in the respective patients, and that is 45 patients. Now there was a significant relations to the swallowing disorder, and we could get LPR cases in 18, the difficulty in swallowing for 19, difficulty in liquids for 9, and for both the dysphagia complaint was present in 4. So in total 43 out of 130 dysphagia complaint was present along with the voice disorder. And now Isha classification classifies structural voice disorder in which there is organic, that means there is some organic voice disorder that results from physical change in voice mechanism, that includes the edema, nodules, polyp, leukoplakia cases. Then neurogenic, in which there is problem from the central or peripheral nervous system, and these include vocal tremors, spasmodic dysphonia, paralysis of vocal cord. And the functional, in which there is a functional disorder from improper or inefficient use of voice mechanism, that is vocal fatigue, muscle tension, dysphonia, aphonia, or ventricular phonation. So these are the distribution of patient as per type of voice disorder. We can see the structural prominented, then neurogenic, and then functional. Then there was one category we created is cannot be classified or fitting into the proper category. Then miscellaneous like alaryngeal, the laryngectomy case, dysphonia with dysarthria, and this aphasia category, then we have taken it as a different category. So these patients were differently classified. Now grade of dysphonia, mild, moderate, severe, based on KP analysis we did. So the moderate dysphonia was present in maximum cases, severe and mild were less. Now this was all the evaluation was done, prosody, falsetto, and all were done. and when we did it, we could find these characteristics: abnormality rate of the speech in 23, prosody in 22. So what was our analysis is there was abnormal rate of speech, asthenia. So these all are prominent features, prosody. So there is some loss of strength, timing and melodic control, and these are pivotal deficiencies in this sample. And then after this, the fatigue patients, we have used the GRAP score, and what we see, the older patients with vocal weakness, with demand vocal, and so they complain of the vocal difficulty in sustaining and maintaining the voice. Then the other is, I have to come there. Prosody and all, that the prevention, there is a prevalence of subtle voice modulation is present, and the pitch modulation says that there is some irregular disorder, so patients are speaking monotonous or irregular speech patterns emerge from them. Now, what is the pathology marked in the structural disorder in which the laryngeal framework was problematic? So here we had a phonatory gap, we have trauma, edema, Rinke's edema, LPR, laryngitis, and so these are the findings: vocal nodule, vocal polyp, and floppy epiglottis we could get in these patients. Now in the patients whom we had a neurological voice disorder, so we see the paralysis and phonatory gap equal representative. Then one had a prolapse epiglottic, arytenoid atrophy and tremor. The third is pathology with functional disorder. So pubophonia was the most prominent category, followed by ventricular phonation and muscle tension dysphonia. Phonatory gap was present in 3 patients. So when we correlated distribution of voice disorder according to the severity of dysphonia as per the CAPE scoring, we could see that in structural, neurogenic, functional, and cannot, everyone was having moderate dysphonia as the most prominent voice disorder. And this, despite this visual trends, there was no statistical correlation between these values as the p-value was high. However, the patients with dysarthria were too less to be represented. Now, this is distribution of patient as per types of aphasia diagnosed. So we had the commonest was the Broca's aphasia, and followed by global aphasia, and then these were the other types of aphasia which were a different category altogether. So this is also, you got more aphasia in the elderly. Now we have correlated the pathology, or what was the distribution of pathology as per the comorbidity. So we can see the hypertension group and atherosclerosis resulted mainly in neurological or functional voice disorder. So this is the neurological and functional voice disorder. Mediastinal resulted in more in the neurological problem. So this is the this is the and now you can see the structural problem. They are so COPD and all resulted more in the structural problem. Thyroid also resulted in the structural and neurological problem. So this was the correlation. And then what we did, correlation of various types of voice disorder with the known etiologies. So we can see that the structural, neurogenic and all disorders were having common. Addiction was there, followed by voice stress, and then trauma and irritants were present more in structural and neurological disorders. Now we did a combination of distribution of voice disorder in each category of occupation. So we see that in Kaufman sections 1, we have very less patients, so they only have a structural and neurogenic problem, while in 2, 3, 4, gradually the structural problem kept on increasing. So the structural problem kept on increasing, and grade 4 we had representation of all the 3: structural, function and neurogenic problem. Now the heat waves told that the elite group had a severity of dysphonia voice uses as per Kaufman-Isakson classification. So grade 1 and 2 have mild to moderate dysphonia. However, the level 4, which were not trained and have not proper voice uses, there was a maximum representation of severe dysphonia cases in these patients. So there was a significant correlation also. So if we stratify correlation of severity of dysphonia as per the voice users, we can see in one we have mild, so they have a better vocal technique, hygiene and early self-monitoring. So if we have some management plan, it can be preventive vocal hygiene, and if it is not responding, then because of high voice demand, they require voice therapy and some phonosurgery. It should be done early because they have a high demand in voice. In type 2, they have lack of formal voice training but faces high vocal demand, so they require structured voice therapy, voice conservatory strategy and workplace support. In moderate, they LPR and smoking are also contributory factors, so ENT evaluation, targeted therapy is required along with voice therapy, voice ergonomics. In type 4, that is severe, they require a community health support and therapy assist is required, and unemployed, the dysphonia might contribute to unemployment, so we have to rehabilitate them and psychosocial support is given. Now, what was the common pathology distribution of severity of dysphonia amongst various endoscopic findings? So what we saw is this measurement was out of 130. So presence of phonatory gap was a very conspicuous finding, and so we had 14 cases with moderate dysphonia, 11 and 3 with severe dysphonia, and severe dysphonia was seen more when phonatory gap was associated with other category, with the congestion or paralysis. If there is a gap, there will be a more voice disorder, and this is the so we have done a correlation of phonatory gap with grade of severity, and the correlation was significant. P-value was less than 0.05, and this reinforces the clinical utility of endoscopic identification of phonatory gap as a prognostic factor. Interventions targeting glottal closure may help to improve voice early. So this is what is cannot be classified category, and in cannot be classified category, phonatory gap can be given because of structural voice paralysis, plexiform laryngitis, neuromuscular discoordination may be seen primarily normal pathology and roughness. However, the primary issue may be incoordination and not structural. And then improvement of breath support like reduced maximum phonation time was present in cannot classify. So we need to improve our investigation in assessing the breathing capacity stroboscopy. And so to conclude this study, so reveals that a significant number of voice disorder present with feature of which elude the standard structural, neurologic and functional classification. Severity of dysphonia increases as voice dependency decreases, likely due to delayed presentation, poor vocal habit and lack of awareness. As per Kaufman-Isakson classification, it has emerged as a powerful tool, and it has stratified the management of these patients. Across our population, the presence of phonatory gap was found a significant factor associated with dysphonia, and KP revealed that the moderate dysphonia was the most present common prevalent complaint. However, suppose the hypothesis that patient often present as a stage of perceptual compromise that is functionally limited but not yet extreme. So there is a class of cannot be classified category with reduced maximum phonation time, abnormal SZ ratio or inability to perform aerodynamic tasks. So these patients make a category which require proper evaluation. Thank you, chairpersons. This was a retrospective study.
When it's electronic media already was told that
anything. The only thing, we did stroboscopy also, but it was not entered in the same registers. Yes, sir. Why you did this aphasia and the different, why not because there were central causes, madam. According to this Isha classification, aphasia is a totally different class. But since they presented the voice disorder, so I just included them in sample. But when it is coming into structural, organic and functional causes, so these reasons were not present. Thank you. Thank you so much.
Thank you, ma'am. I now invite our next speaker, Dr. Yamini Gupta, ma'am.
Good morning all respected chairpersons. I'll be talking on narrowband imaging, which is a newer optical diagnostic tool for early detection of malignant lesions. So as we all know that head neck malignancy is a heterogeneous group arising from different anatomical parts with different prevalence and treatment outcomes. Globally, it's the 6th most common cancer, and at the national level, it's the 2nd most common cancer. And surgical and oncological treatment of large tumors often result in significant mutilation. So early detection of these tumors is the most important factor which will affect the treatment outcomes as well as the prognostic outcomes. So white light basically, when the white light is projected on the surface, it absorbs all the colors. So what happens is that we lack the image contrast. And there is difficulty in differentiating the minute or the early epithelial changes of malignancy. But what NBI does is it uses only the blue and the green light, so it enhances the image contrast. And as we all know that angiogenesis is the critical when there is a transition of pre-malignant to malignant lesions. So neo-angiogenic pattern of vascular mucosa is picked up by this NBI. So narrowband imaging is a novel high-resolution endoscopic optical imaging technique which enhances the details of mucosa and submucosa. So a spatial filter is electronically activated by a switch in the endoscope, which leads to the use of ambient light of wavelengths of 440 to 460, that is blue, and 540 to 560 nanometer, that is green. So NBI modifies the white light of the xenon bulb and it picks the 3 central wavelengths which penetrate the mucosa and the submucosa respectively. So when there is a blue and green light hits the surface, it's absorbed by the hemoglobin in the blood vessels. So the narrowband blue light, that is 450 nanometer, is absorbed by the capillaries in the mucosa, displaying the superficial capillary network. And the green light is absorbed by the vessels in the submucosa, thereby it displays the subepithelial vessels of the tissue. So blood vessels appear darker and gives a significantly better contrast, and we are able to pick the early changes. So what is the normal look like? So when it's blue light, the superficial epithelial layer, the blood vessels will appear brown. So we all know that the normal vasculature is like a clear branching pattern, but when we do NBI, the surface, that is the mucosal, will look brown, whereas the subepithelial layer vessels will appear cyan when the green light is put on it. So this is how we demarcate. But what is the abnormality? When do we say that the thing is abnormal? So usual branching pattern which is seen in the normal capillary bed is lost. Then we have multiple areas of brown spot which are called as intrapapillary capillary loop patterns. And then within the subepithelial layer, we have multiple dilatations, tortuous, crossing over, etc. Thereby, Takano et al. Had described it as in 4 types. Type 1 is characterized by brown spots. Type 2 is dilated tortuous crossing intravascular microvasculature. Type 3 is we have elongated, twisting, meandering IPCLs. And type 4 is intraepithelial capillary loop destruction and neoangiogenesis. And we should remember that the changes in the degree of dilatation, meandering, tortuosity just tells us that how severe is the disease. So with this background, we did a study to assess the role of narrowband imaging endoscopy for early diagnosis of malignant lesion, to study the sensitivity and specificity of NBI, and to assess the accuracy of NBI guided biopsy intraoperatively. So it was a prospective study at the tertiary level hospitals done in 100 patients. We included age group of 20 to 80 years with suspected oral, oropharyngeal and laryngeal lesions. The patients who were excluded were biopsy proven or patients with recurrence of malignancy. The most common age group we found out was 4th decade, which was followed by 5th decade. Males predominated, probably because of the prevalent tobacco chewing and smoking habits more amongst the male. Topographically, the oral cavity lesions were maximum, followed by oropharyngeal and laryngeal lesions. This also we thought could be because the tobacco is kept in the oral cavity for long period and it's early to see the lesion because of the visibility. When we assessed what was the type of IPCL distribution, we found out that the type 1 capillary loop were most common in 38.6%, which was followed by type 2, type 3 and type 4 respectively. When we compared that what was the capillary loop presentation with the biopsy reports, we found out that the type 1 and type 2 IPCL was correlating with well differentiated malignancy. Type 3 was correlating with moderately differentiated malignancy, and type 4 was with the type poorly differentiated cases. That means as the grading of IPCL increased from 1 to 4, the differentiation of malignancy decreased. When we compared the sensitivity and specificity with the white light thing, we found out that the sensitivity as well as the specificity of NBI endoscopy is much higher. Even the positive predictive value and the negative predictive value was high. We compared it with the other studies, so they also had a higher sensitivity and specificity with the NBI as compared to the white line. So these are certain cases of, this was a tongue leukoplakia and this is the NBI picture which is showing brown spots, type 1 IPCL. This is another case of 38 years old patient with ulcer in the mouth for last 1 month. So this is an NBI picture of type 1 with brown spots. Then this is another case which was showing type 2 with dilated crossing over vessels. So to conclude, NBI is more sensitive and promising tool than conventional endoscopy in early and accurate diagnosis. NBI increases the tissue contrast, specifically identifying the neoangiogenesis areas. It is an indicator for the histopathological type and it also helps in taking the biopsy from the target site. So the take-home message is NBI is having high sensitivity, it's a non-invasive thing, early inspection of superficial vascularity. So when we do early diagnosis, we lead to early treatment and thereby we give better quality of life to the patient. So NBI is a promising edging for diagnosis, treatment and follow-up. These were the references. Thank you. In the cake.
What was the
laryngeal cases were around 20%. Oral and oral. Same. It was same.
Thank you, ma'am. We now have a tea break. We will resume our next session, inaugural ceremony in LT5 at 10:30. In LT5, हाँ, at 10:30 in LT5.
यहाँ का क्लोज है, यहाँ का पूरा वो हो चुका है वही वाला, और वहाँ का भी पूरा हो चुका है।
तो एक काम करना,
लंच के बाद बोलिए।
अरे ये वहाँ पे शिफ्ट कर लेते हैं, बेटर है।
ओके।